Yep.
Okay, great. So it's 5 o'clock. I think people are just slowly filtering in, but we'll start with a little bit of housekeeping. I know everyone's probably quite familiar with Zoom by now, but this session is a webinar style session. So you will be muted for the presentation. However, there is at the bottom of your screen a Q&A feature where you can ask questions throughout the presentation, and also a chat feature if you're having any technical difficulties. Once we've finished with the presentation, we can unmute mics if you raise your hand, if we want to have a little bit of dialogue. So thank you all for coming, and I will maybe pass it over to Dr. Sean Keenan.
Thanks, Heidi, and thank you everybody for attending today. It's good to have you all here at the end of a long day. My name is Sean Keenan. I'm the Provincial Medical Director for Donation Services at BC Transplant, and presenting with me today and doing most of the work is Heidi Butler, who's our manager, and Karen Qatar, who is our educational lead at BC Transplant. And the format is going to be us presenting for about half an hour, and then opening the floor up to all questions. Anything else to add, Heidi, Karen?
No, that sounds great. I think
Okay.
we've got about 37 people, so I think we can maybe get started. Karen will just share her screen here shortly. There we go.
Okay. And Karen, are you going to advance the slides? Is that going to, yes? Okay. All right. So, yeah, again, thank you for being here this evening. Karen, can you advance the slide, please? Okay. The objectives of this evening are to start off, I'll be going over the history of organ donation made in Canada, and then I'm going to hand over to Heidi and Karen, who will review the current process, including referrals, eligibility, suggested languaging, organ donation workup and testing, what happens on the day of provision, and the declaration of death. We'll also provide some resources and a case study, and then open up to questions and answer period. So you know this better than I, so I apologize for even going over this, but in June 16th, the MAiD legislation was passed in Canada. While there was a case of donation following MAiD in 2016 in Ontario, the first case in BC was not until 2017. And then we use what we refer to as a modified donation after circulatory death approach to it, and you'll hear more about that. In May of 2017, the Canadian Blood Services sponsored a national workshop entitled Organ and Tissue Donation in the Conscious Competent Patient. And while this focused mainly on donation following MAiD, it also included all people who were awake and able to make decision makers, such as those that are on long-term ventilation. At this conference, they had medical, legal, and ethical experts, also patients considering MAiD and organ donation, and an expert from Belgium, which has a history of MAiD and organ donation that precedes us by a number of years. In the 2 years later, the article Deceased Organ Donation, Organ and Tissue Donation After Medical Assistance in Dying, and other conscious and competent donors guidance policy was published in the Canadian Medical Association Journal, and you're probably familiar with this. The main outcomes regarding this from that conference were it was felt that the opportunity to donate organ and tissue should be offered to every medically eligible person seeking MAiD as part of high quality end-of-life care, that this is just something that should be made available to them. Each patient should be extended autonomy and dignity to provide this first-person consent in accordance with their own preferences. The decision to seek MAiD should be made prior, obviously, then to the initiation of any discussion of organ and tissue donation. Organ donation, procurement, and transplant teams must not influence the patient's decisions or approval to receive medical assistance in dying. This idea of very clear separation. In 2020, there is a short article published in the New England Journal of Medicine. It's a cohort study of the experience of 3 provinces, British Columbia, Quebec, and Ontario. from June 2016 to January 2019. And in that study, they had a total of 56 referrals for donation following MAiD. Those referred had a mean age of 61, 39% female. The primary diagnosis was ALS, followed by COPD and Parkinson's disease. Of the 56, 30 went on to become organ donors and in total donated 74 organs. BCT at that time also consulted with donation partners in other provinces to help develop a more robust process. So while we had been involved in cases, we really started pulling things together again at that time. This is just a summary updated to 2020, looking again at the 3 provinces that were participating in this, and Ontario is by far ahead as far as number of donors. Of course, it's also a much larger province. Over this time, they had 43 donors, Quebec 23, and British Columbia 6. And you can see the number of organs that have come from this, and these are all, life-saving events for these patients. The BC experience sort of extended from there, from 2017 to March 2021. We've had a total of 48 referrals that have been logged. Of these 48, 7 went on for actual donation after MAiD. It's happened in all health authorities except the Northern Health Authority to date. And currently, BC Transplant in-hospital coordinators are working in various sites across the health authorities in BC to develop what we refer to as modified DCT policies and processes. These are at various stages of completion. Some are fully completed, other ones are still being worked on. And in addition, BC Transplant has been working with the Ministry of Health to create a guiding policy for donation following MAiD.
Thanks, Sean.
Thanks.
So this is really just a high-level overview of what we're going to be going through. Takes you through the process from referral to workup, day of provision, declaration of death in the context of organ donation, the organ recovery, and the aftercare and family support. So as we go through this, Kieran and I are going to do our best to really delineate the role of BC Transplant and the coordinators, and then also the role of the providers and the care clinics. So really starting off with the referral, the Human Tissue Gift Act is the legislation in British Columbia that really governs all things organ and tissue donation. Part of this act is a universal referral process. So the act actually reads that all deaths and impending deaths in the case of MAiD are to be reported to a donor referral line. And really what's important about this is this universal referral process ensures that we are consistent with this legislation, and especially for eligible MAiD patients. It really allows BC Transplant to check the registry status to see if these patients have registered their intent to donate. And really most importantly, it allows patients to be provided with the option of organ donation as a part of their end of life planning. As Sean mentioned, we've had about 7 cases in BC. And so we know that when presented with this option, patients are interested. So our referral process, so our former process really was variable. It has differed from one health authority to the other. And in those 7 cases, most of those were initiated by the patient. Our current process and what we're here to really talk about today is that really all patients who have had both assessments done should be offered the option to speak with an eye or organ donation coordinator to explore donation at end of life. So the way these referrals can come through can come from MAiD coordinators, they can come from GPs, MAiD assessors, providers, and the patients themselves. So we've put together a ton of resources on our website, one of which is a referral algorithm. So it is available on our site, and I won't go through it in a whole lot of detail, but just know that it's there for you. It basically walks through the patient has been approved for MAiD, lets you know whether it's a referral that should be coming to BC Transplant or the iBank, what to do if the patient is interested, and really just kind of walks you through the whole process up to the point where we then get involved. So something new you will notice on your 1634 forms, so section 7 under planning of medical assistance in dying, you will notice there is a new question on here that says, has the patient been offered the option to speak to a coordinator at BC Transplant or the iBank? And are there any exclusion criteria for organ or tissue donation? And these can be found at our website. So we pulled these right out for you today just to have them up front. So exclusion criteria for organ donation, patients who have HIV, who are older than 80 years of age and have metastatic cancer. Hard exclusions for eye donation are patients with ALS, MS, Alzheimer's, Parkinson's, and greater than 75 years of age. So we get these questions quite frequently around eligibility, so we thought we'd pull them right out for you. So neuromuscular disease is not a rule out for organ donation, and we really evaluate these cases and all cases on a case-by-case basis with our medical director. In order for a patient to be eligible, we need to know that there is at least one organ in good function with acceptable lab values and diagnostics. And the organs that we can evaluate for donation for these patients include their lungs, liver, kidneys, whole pancreas, and or islet cells. So Kieran will get into a little bit more detail about why you'll notice the heart is missing in this, but that really has to do with the donation after circulatory death. So in cases for donation after MAiD, the heart cannot be evaluated for donation. So patients also in the context of donation, they have to be willing to have their provision in a hospital. They also have to be willing to have the IV medication delivery route. Right now in BC, or home organ donation is not an option following MAiD, and this is really just due to logistics. It has to be quite coordinated. The patient needs to be close to an operating room in order for us to be able to safely recover and transplant organs. So the $1 million question, how do I ask my patient if they're interested in speaking to someone from BC Transplant? It's a great question. We know you're not familiar with donation, so we are happy to share a few examples of some languaging. So we've come up with a few scenarios. So the first scenario here is on second assessment. The MAiD provider is discussing options with the patient. So you can consider, have you considered organ donation as a part of your end-of-life plan? I can have someone from BC Transplant provide you more information if you would like to explore this option further. Or really simply put, I am required to provide you with all of your options at end of life, and organ donation is one of these. I am happy to put you in touch with a knowledgeable organ donation specialist or iBank coordinator to provide you with more information. The second scenario here is really anytime before both assessments are completed and the patient asks you about organ donation. We would suggest this. So organ donation is possible at end of life in some cases. After your second assessment is complete, I would be happy to put you in contact with BC Transplant or the iBank to determine if this is an option that would align with your end of life planning. So really in this scenario, trying to separate that the decision and approval and assessment for MAiD needs to come ahead of any in-depth discussions around donation. And last scenario here, number 3, probably maybe one you would be familiar with more often is a patient that you are seeing that has metastatic cancer, and they inquire about options around organ donation at any point in their MAiD assessment process. So your response could be, unfortunately, due to your diagnosis of cancer, solid organ donation is not an option. However, we can certainly call the iBank as there may be an opportunity for eye donation. So you have approached the patient and offered them the option to have this conversation, and they are now interested. So what is next? Going back to your 1634 form, patient is interested, and you'll see a link to a website that goes directly to the BC Transplant web and has our referral form. So this is our referral form. Again, the exclusion criteria is here right at the bottom. We would ask that you either fax or email this to us. If the provision is going to be in less than 10 days from the referral date, we would ask that you call us directly. We really want to make sure that we can mobilize ourselves to be able to provide this option to the patient if they so choose. So in our referral form, we do ask a lot of information, all of it though very important. We ask about the patient's contact. Do they have any language barriers? Do we need to arrange for a translator? Do they have a caregiver or a support person? Who is referring them? Who is their family physician? We would like you to indicate that both assessments have been completed. We would like to know that they have met all the exclusion criteria or they do not have any of that. Their diagnosis, and if they have a preferred hospital where their provision might be. Okay, so your patient has been approved for MAiD. They've had 2 assessments done. They do not have any of the exclusion criteria that we've listed and spoke about. They have agreed that they'd really love to speak to someone from BC Transplant to see if this is an option that aligns with their end of life planning. And you have filled out the referral form and you have sent it off to us. Your patient qualifies for a donation. And now I'm going to hand it to Kieran and she's going to really review what we do next with that when we receive that referral.
Thanks, Heidi. So your patient's been referred to BC Transplant. The next steps would be that a coordinator from BCT will meet with the patient and the family if they wish to be there to discuss organ donation. So we'll explain the process, we'll answer any questions they might have. And if this aligns with their wishes, we would move on to doing a formal first person consent and a medical social questionnaire. The medical social questionnaire is a really comprehensive set of questions that we ask every donor family in an intensive care unit, which extends to MAiD patients. And it's just a very in-depth look at medical, social, behavioral history so we can know if we need to flag for anything that may be considered high risk. One thing that we make very, very clear to the patients is that the consent process for organ donation is completely autonomous and independent of the decision to seek MAiD. So we make sure that they know that they can rescind their consent for donation at any time, literally the morning of their provision. If it's just not the right decision for them anymore, they can rescind their consent for donation and it will not affect their MAiD provision in any way. Some of the workup that we require for donation is a physical assessment form that can be filled out by an MD or an RN. We require mandatory blood work, and obviously right now we are requiring a COVID swab that's done within 5 days of the provision date. The other thing we ask for is organ-specific testing. This is preferred by us, obviously, so we can evaluate certain organs, but we also do recognize that there's limitations for some patients who can't, for example, lay flat in the CT scan or just can't get to the hospital. So although it's preferred, we will work with the patient to work around organ-specific testing if we need to. Most importantly, we do make all efforts to ensure that we're doing our best to balance the burden of testing against the safety of the organs we're transplanting. So the patients are always involved very collaboratively with BC Transplant in all of their planning, the timing of the testing, where they can go, what physical limitations they may have. The nice thing about the testing that we are able to facilitate at home is we have a process with Life Labs where blood work can be actually drawn at the patient's house if they can't make it to a lab or a hospital. So big question we've gotten is, what is my responsibility in all of this, being the providers and the MAiD coordinators and the clinics? So one thing I really want to emphasize here is that the entire process of organ donation after MAiD is very collaborative. So BC Transplant, the hospital, the MAiD care clinics, providers, the patients are all very involved in the planning of every single case. But what I really wanted to emphasize with this slide is that there's certain things that BC Transplant does sort of take the onus on that we don't want the providers or the MAiD care clinics to have to worry about. So blood work, the diagnostic testing, the COVID testing, the majority of the logistics within the hospital, when we're starting a case, admission, location, etc., is mostly driven by both BC Transplant. What we really want the providers to focus on is the assessments, the referral, and then the actual provision itself, obviously. We do look for the providers to fill out the physical assessment form if possible, but having said that, it can be an assessor, a prescriber, it can be their GP, it can be a specialist who they have a relationship with. We just will probably come to the providers first. And the other thing we look to the MAiD programs to facilitate is the actual hospital admission. So BC Transplant wouldn't be admitting the patient, it would be the MAiD clinics admitting the patient under their provider. And then obviously the patient is very much involved in the timing of everything that's happening as well. So just wanted to be clear that everything's collaborative, but there are certain things that we're very aware how busy the MAiD clinics are. And everybody is across the province with MAiD. And so there are certain things that BC Transplant wants to ensure that you know that we will take on the burden of those things. So before we get into what the day of looks like, I just wanted to briefly touch on DCD. So Sean mentioned DCD early in the presentation. There's a lot of acronyms at BC Transplant, but DCD is donation after circulatory death, which is the pathway that we observe in donors who are not neurologically deceased. So typically in a critical care area, patients are either neurologically deceased or they have an impending death when they're removed from life support. And we wait for cardiac standstill before we would go to the operating room. MAiD patients will follow this pathway. So it's called a modified DCD just because instead of withdrawal of life support, there will be a MAiD provision done instead. Death is declared after 5-minute period where we're sure there's no longer any circulation. There will be 2 physicians who are independently licensed to practice in BC who are declaring death. Usually one is the prescriber and the second is organized by BC Transplant. Sometimes they're, a prescriber, an assessor, an intensivist, a hospitalist, but BC Transplant will do the work to figure out who the second is. One question I know we will get asked is, why do the 2 declarers have to be physicians? Because I know a lot of you use NPs. Currently, in the context of organ donation, the legislation does read that the declarers for death in donation have to be 2 independently licensed medical practitioners. And the College of Physicians has defined medical practitioners as MDs, not NPs. So that's kind of what we are bound by to follow right now. And then once the patient has had their 5 minutes with no circulation, they'll be declared dead and taken into the operating room immediately. I'll go through this more in a step-by-step process in a couple of slides here. So day of provision, patient is admitted prior to provision, usually an hour or 2 before. That's kind of coordinated between the patient, BC Transplant, and the hospital. And the admission, again, is the responsibility of the MAiD programs, but supported by BC Transplant because we'll have a bit of a say in where the location is based on proximity to the operating room. Our surgeons will be on standby in the operating room. There will be a coordinator from BC Transplant in the unit where the provision will be happening to help facilitate everything on the provision side of things. And the patient will be set up to some cardiac monitoring, so an ECG, oxygen monitoring through SPO, through a SAT probe, and occasionally they'll also have blood pressure monitoring in the form of an arterial line. So a caveat here is that arterial line monitoring is preferred because it is what we use in the context of DCD in a critical care area, but the patient isn't required to consent to an arterial line. So the practice of an art line across the province is going to be very varied depending on health authority, the hospital, the patient obviously primarily needs to consent to this. So there'll be a lot of factors that go into whether they have an art line or not, and that will be organized with the in-hospital coordinators as they're developing these policies at each site. BC Transplant will run a huddle prior to the provision just to make sure everybody is really comfortable, that everyone's roles are established, and they'll walk through the process one more time. We require that a dose of heparin is given to every potential donor case, 400 units per kilogram, which is a big dose. It's ordered by the provider ahead of time and administered by the, ordered by the prescriber and administered by the prescriber during the provision. And that's just to prevent any blood clots from forming, because we do have that 5-minute period where we're looking for cessation of circulation. So we just want to prevent clots to the organs. One other question we get is, when do I give the heparin? That's also varied a little bit. The most important thing to us is that the heparin has a chance to circulate. And so in the cases that we've done, it's either been given right before the provision drugs or right after the sedative portion of the provision drugs. So I think after the MAiD is given. We have 2 physicians there again to declare death, one usually the prescriber, the second one will vary and be organized by us. The provisions carried out as per usual. Your process shouldn't change when it comes to your provision, with the exception of the heparin dose administration. And then once death is determined, and I'll get to the slide of how we determine death in context of donation, a 5-minute observation period is initiated in which the patient is monitored to ensure there is no spontaneous return of circulation. At some point in that 5-minute observation period, depending how far we are from the operating room, we would actually start moving towards the operating room. So for example, a palliative ward that's a few hallways down from the operating room, we might start walking towards the OR with both physicians, the coordinator from BCT, the nurse on a transport monitor. And at the operating room doors, both physicians will then declare the patient deceased and they'll move into the operating room. So families are present through all of this if they wish to be, and if the patient wishes for them to be. They're very well versed by BC Transplant that the process is very quick, that as soon as their loved ones declared deceased, within 5 minutes we're in the operating room. So they're very well supported. Nothing comes as a surprise to them, and we'll ensure that they have a support system in place at the bedside when we do leave. And post-recovery, patient's body is moved to the morgue and whatever funeral arrangements from there. The exception to this is very case by case. We don't generally encourage bodies being brought back because they do not look the same. Not necessarily because of the incision, but they're deceased, they don't have circulation, they've been exsanguinated. So unless it's for a very strong spiritual reason, we don't generally recommend it, but we will help facilitate it if it's a necessity. So just to walk through the determination of death, you've pushed your drugs. The next step would be to assess for circulatory arrest. So that's done through absence of a palpable pulse and pulse pressure on an arterial line if you have one. If you don't, absence of heart sounds, pulse, and confirmation of electrical asystole on the ECG. One of those combined with no respiration and no response to noxious stimuli is how you know your patient's in circulatory arrest, and you would start your 5-minute timer. Post 5 minutes of observing the patient to make sure there's no return of circulation, both physicians will then do a second assessment. So they'll look for continued absence of pulse and arterial line asystole or electrical asystole, along with a continued absence of respiration, pupillary response, and response to noxious stimuli. So at that post 5-minute mark in this assessment, that's the official time of death, and the patient will move right into the operating room. This is what our form looks like. This is a BC Transplant confirmation of death form. There's a section at the top here where we would record the onset of circulatory arrest, and here would be when both physicians have done that final post 5-minute assessment, and that's the illegal time of death. This form will be provided by BC Transplant, but I did link the location here in case anyone wanted to take a closer look at it. The important thing I want to point out with this form is that this is for the intention to show that the patient is deceased for donation. It does not replace any paperwork that you're required to fill out, like a record of death, so you'd still have to do that. All the resources that we talked about here are available at our website, transplant.bc.ca. They're all listed here. One thing we didn't mention is we do have a MAiD provider toolkit. That's a really comprehensive resource for healthcare practitioners about this process. And it basically covers everything we've talked about in this presentation, but in more depth. So this is what our website looks like. There's a tab at the top labeled Health Professionals. If you click on that, it'll take you to a organ donation resource page. And at the bottom, you see there's an organ donation after MAiD tab. And that will take you to all of the resources, the physical assessment form, the toolkit, that referral form, as well as that extensive algorithm that Heidi mentioned earlier. So finally, just to pull all this information together, we thought we'd do a really quick review of a case study of a real case. So this was a 64-year-old male, primary diagnosis of end-stage MS. So day one, patient was referred by the prescriber. Upon approaching the subject with the patient, which actually worked out quite well because it turns out that this patient was actually registered. So, you know, he had already had a pre-existing wish to be a donor. So it had been brought up to him, which is fantastic. Once we did the registry check and reviewed his medical records and established he would be eligible for donation, we reached out to the patient. This was on a Friday. This is why there was a bit of a gap here. Reached out to the patient and set up a meeting with the patient and the family, walked him through the process, did the formal consent and medical social questionnaire, and then notified the prescriber that the patient had consented for donation and started our planning. Day 5 to 6, we did some logistics, notified all the stakeholders that there was a potential donor that will be happening at whatever chosen hospital that was, made sure that the MAiD coordinators and everybody was looped in and all the planning had started. BC Transplant Coordinator was able to order all of the labs and set up the blood work draw times in collaboration with the patient's transfer needs. By day 7, patient was having their outpatient labs drawn. They had no diagnostics ordered because they were unable to lay flat for imaging. So this is one of those cases where we just worked around not having any imaging. Day 8 to 11, BC Transplant was doing all of their usual work in the background, allocating organs, just finishing off any logistics, charting, stakeholder communication. Day 12, the patient had their provision. They were admitted an hour and a half prior. They had their IV inserted, placed on a stretcher, had an arterial line in this case inserted because it was the preference of this specific site, and cardiac monitoring was established. BC Transplant then led a huddle about 30 minutes prior to the provision to review roles and responsibilities, and to observe a moment of silence for the patient, which we do with all of our donors. And then the MAiD provision was carried out as per usual. The second observing physician was an MD from ICU. So this is just a timeline of what things look like. So at 20:05, the drugs were pushed along with the heparin. At 20:10, the patient went into circulatory arrest, and that 5-minute timer was started after the assessment by the physicians. At 20:15, so in that 5-minute period where we're looking for to ensure there's no rebound in circulation, at the end of that, the patient was declared after the 2 physician exams, and that was the official time of death. And by 2017, the patient was in the operating room for recovery. And this patient was able to gift his liver for transplant and his islet cells for research. And finally, I just wanted to sort of round things off with a quote from a donor family. This was a family whose loved one went on to donate organs through after medical assistance and dying. And I really wanted to highlight the fact that donation is not just impactful to the patient themselves, but really to the family who's left behind in the aftermath of everything. So John, the names have been changed here, by the way. John was glad to be able to help others, and this truly reflected his philosophy in life and one we pass on to our daughter. We had a letter from one of the recipients who was a father of 3, and he expressed how thankful he was for the opportunity his organ transplant has given him to continue to be in his children's lives. We both know how important that is, and it especially resonates with me as I know that this is what John had wanted the most for himself and our daughter. So I just wanted to throw a slide in with any contact information for anyone that you need to get a hold of, BC Transplant or the iBank, and we will open the floor up for questions now. Shannon Leonard from the iBank, the Donor Development Liaison from iBank, is also on this call. So if there's anything specific to iBank questions, she is available to answer those as well. So we have some questions that were submitted through the Q&A. So I'll go through those first, and after we're done those, if anybody wants to ask a question, if they could raise their hand, we can unmute you to ask that question as well. So Stephanie has asked a question. Please verify for the many who have asked, should be referred or must be referred, and who is checking? Heidi, do you want to answer that one?
I'm going to give that one to Sean.
Okay.
Thanks. I know the languaging can be sort of difficult here sometimes because there's an idea of how much of an imperative there is here. I think it's important to recognize why there is the actual law in place, and it's really there to try to ensure that people do have the option of organ donation at end of life. It was focusing clearly on hospitals because that's the only place where organ donors were. And really it is a kind of must, should, like imperative, but it's not something that's enforced in any way. We do medical record reviews in hospitals to try to see cases that were missed and provide feedback, but there's nothing punitive at all. I think what I'd like to emphasize is what this is trying to sort of emphasize is that we want to give that option to people. And if you don't give that option, then you've really made the decision for them. It's important to let them have the option to decide. And so I hope that helps somewhat, but nobody's going to be enforcing, but there may be some feedback eventually once things get more robust.
Thanks, Sean. So I can answer this next one. Can admission be to any hospital or only specific hospitals? For example, I admit to, I won't say where, just so in case anyone wants anonymity here. So right now our hospital coordinators are working really, our in-hospital coordinators are working really hard to develop policies where we can try and do donation after MAiD at any hospital. The difficulty lies in the fact that there are some hospitals that don't do donation currently just because they have a lack of resources or they're not a big enough center. Some hospitals don't have an operating room that can facilitate organ recovery. But the short answer is that we will try our best to facilitate the provision and the donation happening at the patient's first choice or closest hospital to them. But we're also very transparent that that might not be an option and we may have to go to a slightly bigger center that can facilitate it, but we'll always look into it first.
We missed a one there that by Keith de Villiers.
Yeah. So I'm going to let Heidi answer this one, but is there a good reason why BC Transplant requires their own referral form instead of the 1634? Can that not simply be copied to BC Transplant if we've ticked yes to patient wants to speak to someone from BC Transplant?
Yeah, it's a great question and it's not a bad idea. We have kind of been working with the ministry and the MAiD Provincial Steering Committee to kind of give us some feedback on some of this information that we've created. So one of the suggestions was actually this referral form. I think it's been a bit split, but a bit of hesitancy in sharing those assessment forms with BC Transplant until we're directly involved. So I think for the time being, our referral form will be the way you would go to refer a patient, but we are certainly open to making improvements in this process, and we want to hear your feedback because you're the ones that do the work. So for now, the referral form as well, because there is a lot of stuff on there that's I think extra that wouldn't be on your assessment forms, but always open to feedback and happy to hear it.
Sean, do you want to answer this next one about, are both MDs required to check for lack of pupillary response?
I personally don't look for pupillary response when I'm assessing somebody and DCD. I think the idea is that both MDs should be doing the same exam. The main thing clearly is cessation of circulation and respiration and then noxious stimuli. Trying to be respectful at the same time, because it can be distressing for family members if things are too aggressive and how they do that. I personally, so if that's what you like to do, then it would be ideal to have both people do it. But I don't know if that's absolutely necessary. I hope that helps.
So this next question I can answer, but Sean, if I might just ask you to weigh in if I'm not answering it correctly. But the question here is essentially, if we have circulatory arrest before any of the drugs have finished being administered, would it complicate timing? Because normally you wouldn't stop to check for circulatory arrest while pushing your drugs. So I think the consensus we've come to through a few different conversations is that we want you to do your MAiD provision how you would normally do it, which is you would push all of your medications. And we wouldn't expect you to stop halfway through to do your assessments to start that 5-minute timer. So you would finish all of your drugs, and that might mean that the patient's in circulatory arrest before you're finished. But we don't want you to modify your process at all. So just finish pushing your drugs, and then you would finish, and both physicians would do their initial assessment of circulatory arrest. Does that sound right, Sean?
Yes. What we may do is the timing wise. I mean, if somebody meets our criteria for, no electrical asystole or no, we could potentially start the clock. Is that what you're saying, Karen? But we still want you to complete what you're doing. So, it probably will be something that, as we get more experience, we're going to think further on as to what to do. But right now, we would just ask you to do what you normally would do. And if this becomes a situation, because really, it wouldn't be that much of a delay, I don't believe. If it's delaying several minutes, then we might have to reconsider things. But for now, we just ask you to go ahead and do that.
Will an in-person assessment by someone from BCT be possible throughout the province, even in remote settings, in a timely manner? So yes, if you mean in-person assessment, meaning an in-person meeting with somebody who's interested in organ donation, we do have coordinators across the province. So we have 2 coordinators in interior. We do have some casual and actually we have a 3rd casual. We have a casual coordinator in Northern. We have several on the Lower Mainland, a couple on the island. So it depends where the location is and where the patient's at. Unfortunately, we can't make it everywhere across the province, and a lot of these meetings will happen over the phone or Zoom or Skype or FaceTime, whatever the patient's most comfortable with. But if at any point we can have a coordinator meet somebody in person, we always do try. So in FHA, are we using all hospitals or just the big 3 for provision and donation? No, we are trying to use every hospital in FHA. So the coordinators for FHA are working with several sites right now to facilitate donation. Off the top of my head, Abbey, Burnaby, Surrey, RCH are all, Ridge Meadows are all sort of options right now. And we are working on some of the smaller sites as well. Do we need to put on the form 1630 for the reason that we didn't refer to BCT? You want to answer that, Heidi?
Yeah, sure. Right now, no, we don't. I think, as Sean mentioned, when we get more experience with this, when more referrals come in, we will probably work quite closely with the ministry and see whether we need to be updating, changing any of these forms. But I think for now, no, we just really want you to ask the question and get comfortable with that. And then we'll look at amendments in the future, I'm sure.
I'd like to hear about the details about eye donation, who notifies them. So Shannon, do you want to answer this one?
Hi, yes. So who notifies them if they're eligible, I think is the question. So the iBank coordinator can speak with the family and discuss eye donation and obtain consent if that hasn't already been completed. And we can be the resource for the family. For actually notifying us that the patient's passed comes usually from the provider or one of the healthcare professionals that's present can call the iBank directly and let us know. And we usually have, well, we've always been let know the time beforehand so that we could have our recovery tech available to come out to the facility to do the recovery. So we'll set everything up ahead of time. I hope that answered the question.
Shannon, just this is like a question I just thought of too that people may have is for cases of MAiD that are being done at home, are you able to send somebody for recovery?
Yeah, so what we'll do is we'll set it up with funeral home and do the recovery in the funeral home afterwards. Yeah, so that's just something we need to confirm that the funeral home has the facilities and will also give us permission to do that, but we can check that beforehand.
Okay, great. Does a referral form get sent in even though the patient refuses because the MAiD form looks like it does? So does the mandatory notification policy use site? So I guess Heidi sort of answered this in that if the patient isn't interested or they haven't been asked for whatever reason, there's no expectation that you're sending in the referral form to us. Again, sometime in the future, we might revisit how we do this for the sake of being able to collect some stats and see if there's some changes we can make, but right now it's not an expectation. Can you speak further on what support is offered to the patients' families after donation? Do you want to answer that, Heidi?
Yeah, sure. So we have a family services coordinator, Jordy, who is a social worker that works with our team. So he connects back with the families of these patients if they would like to be contacted and can offer support, weeks, months, years down the road. So he's wonderful and he's done a lot for the family services program. So we have him.
Thanks. These next couple look like they're going to be for Sean. So which noxious stimuli is checked for, bearing in mind the whole family may be present?
Yeah. I mean, I tend to be, everybody's somewhat different. Conventional DCD, death declaration, generally there's an art line in, but you'll often see, EKG also becomes isoelectric. We go into the room, we sort of observe, auscultate. I don't know how much noxious stimulus honestly adds to that. I mean, some will, but I would try to be discreet. Could squeeze the traps, things like that. That just gentle squeezes. But going in and using pens and things like that on fingers and toes, I just that just doesn't make sense to me. A nasal tickle is something that's very noxious but looks a bit odd. So probably if you're going to use it, just a trap squeeze and see. That would be what I would suggest.
And then next question for you, Sean. What about the use of bupivacaine in these patients? Should that not become routine?
Yeah, so this is sort of interesting to me. I mean, one thing in working, my background is also as an intensivist. I stopped working there in June, but one thing that in the ICU that we went through a lot of sort of looking at is doing things the same way, regardless of whether donation is an issue or not. So the bupivacaine, because of the effect on the heart, I think that's what you're referring to. It certainly would maybe make things happen faster. And so you think on the setting of this person wants to be an organ donor and first person consent, and that would make sense. It's a bit different too, again, in the setting in the ICU, because there we're not trying to actively hasten death. So I have a little bit of a different perspective. We're keeping people comfortable, withdrawing life support, and they may or may not die in that time frame. In this setting where the goal is bringing on their death, then maybe there's not the same sort of idea of doing things always the same. But I would really, we would never, I think, in our should be coming forward and suggesting a way of doing it to you. It should be something that I think comes from you, because we just follow the death, really. Does that, hope that makes sense?
Yeah, I think this next question is the same. It's a Vivicaine question, so hopefully that was answered. My understanding is that the conversation regarding organ donation does not occur until the prescriber assessment. Is that correct? How would you advise MAiD coordinators to advise patients if they ask prior to that? So yes, we would ask that organ donation not be approached by the MAiD coordinators or the prescriber assessor until the second assessment is done, just to ensure that there is a separation between the two decisions. If a patient asks for it prior to that, if in this presentation, which we can probably send out to all of the different coordinator clinics, there's several slides that Heidi went over that talk about that situation and how to approach it if a patient brings it up prior to those assessments.
I think, Kieran, just to add to that a bit, I think we're always willing to share general information like we would share with any member of the public that called the BC Transplant line. We just don't really want to get into any specifics with a patient that might influence their decision to move forward with a second assessment. So that's kind of where we draw the line there.
And Kieran, I wonder if I can just address something sort of separate from that, because it was in the chat regarding, you know, the unfortunate situation with the current Human Tissue Gift Act, referring to the need to have medical practitioners for declaration of death. This is, you know, something, first of all, that I don't personally believe is necessary. Where I worked in the ICU, nurses declared death almost all the time. I would rarely ever do it except in the context of DCD. It's just something that legally at this point we're kind of stuck with. Now, that has nothing to do with the provision of MAiD, though. You know, there's nothing in anywhere that says a doctor has to do the MAiD provision. It's death declaration. Now, while it's more awkward, not awkward, but maybe it requires more manpower or person power, whatever. I can't see why a nurse practitioner couldn't do the MAiD provision, but we would need 2 MDs to do the death declaration. Seems a bit cumbersome, but I just don't want, I don't want to anybody feel offended by, you know, the nurse practitioner versus MD. We're kind of stuck with it, and we would like to see that changed, and I think it will be changed at some point. But it doesn't mean you can't be the provider, to me at least. Oh.
Yep. If we know that the patient has exclusion criteria, we're still expected to ask them to talk to a donation person. Nope, we would just ask again that you're checking that there's difference between eye exclusion and solid organ. So they may still be a candidate for eye, if not for solid organ, and vice versa. So just to be checking both exclusion criteria. Otherwise we don't expect them for you to ask them. And if they ask, you have the answer in front of you that they would be excluded for whatever reason. Why can't people that have ALS, MS, Parkinson's, and Alzheimer's be eye donors? Shannon, I'll leave that one to you.
So they are not rule outs for eye donation in themselves. They're rule outs because they have symptoms that are like mad cow disease, Creutzfeldt-Jakob disease. And because we can only diagnose it at with a brain biopsy at autopsy, we can't use that as a diagnostic to determine if the person would be eligible or not. So at this point, anybody who has a condition that has symptoms alike Creutzfeldt-Jakob is ruled out for eye donation. So it's MS, ALS, Parkinson's, dementia, and Alzheimer's, unfortunately.
And I think, I'm not an expert in eyes, but it may seem odd that we would give lungs to somebody, but we wouldn't give eyes. But it's also the life-saving aspect as opposed to improving your quality of life. It means a lot to have, the corneal transplants. But if somebody's dying because their lung or liver and they've got a short period to live, the very, very small risk involved of anything like that, it is overcome. Yeah.
Yeah, that's the Human Tissue Gift Act has different criteria for organs versus eyes, blood, and tissue are grouped together under, so different criteria.
Yeah.
Thank you for clarifying that.
No, that's good. Yeah,
That's perfect.
Have you had to navigate cases where the patient is keen on donation, but the next of kin aren't? Any tips? Yes, we do navigate those cases quite often in a critical care setting. We have actually, I think, navigated a couple of MAiD cases as well. In a critical care setting, the family does actually have the option to override a patient's registry, for example, if they're registered wanting to be a donor. In cases of MAiD, because it's first person consent, a family would never be able to override a decision made by somebody in the first person. How we would navigate that is, I think our best tool is education and information. So we always offer to have the families present for the conversations, for our meetings. We make sure that they're very well informed on, you know, what the process is going to look like. They have their opportunity to have their questions answered and their fears heard, and any explanations they might need to just make the process a bit more easier for them to digest. Often, obviously, the hesitation isn't necessarily donation. It's probably more related to the actual provision, which we can't, you know, really help. But if we can offer a conversation to the family, we're always willing to answer any questions they might have as well. And lastly, we have on form 1634, it asks if someone answers yes or no to being offered the option, but there's no option to say, yes, we've offered, but they have refused. If we change 1634 to give this option so that all providers can obey the requirements to offer donation, but also say the patient is not interested, would you have objections to that? No, I think that would be our preference, actually. Heidi, do you want to answer that one?
Yeah, no, Kieran, I agree with you. I think, I mean, this is new for this universal process, and this being on the forums is new for everyone. So like I said, we're more than happy to work with the providers and the ministry to take this feedback and make this a bit more user-friendly and hopefully a good experience for everyone. So
that's all the submitted questions. I'm not sure if there's anybody who wanted to verbally ask a question. If you do, you can raise your hand and we should be able to see it, and we can unmute you if you have any questions.
And I know the question came up a lot about releasing this presentation, and we're happy to share this presentation, and we will be doing it again on May the 12th for anyone that maybe couldn't attend or really wants to hear it again. We'll be doing it again then.
And the session is recorded as well.
Yeah.
So we will at some point figure out where the recording will live, probably our website, I'm going to say, if we can get it on there. But we'll have a recording of this as well in case anybody wants to go back and listen. See another question here. Are you able to get temporary MAiD privileges or a new provider sorted out quickly if a patient wants to donate after MAiD, but their intended prescriber does not have privileges at the target hospital? Yeah, so this is something that our in-hospital coordinators are working on, is to figure out how privileges work within. There's some health authorities where MAiD providers actually have privilege to admit to any hospital, and it's slightly different in other health authorities. So I think they're doing the work right now in the background to figure out how that works, and it certainly won't be a barrier. At the end of the day, if we need the patient admitted somewhere where the prescriber doesn't have admitting privileges, we will figure out a way to have them admitted, whether that's under, you know, the ICU or the second declaring physician or whatever, but it won't be a barrier at all.
I think we're right on time there, 6 o'clock on the nose. So thank you everyone for joining tonight. We appreciate all the questions and feedback, and we look forward to chatting with you soon. And if you have any questions at all, please call or email the numbers on the contact screen. Happy to chat.